So today we're talking about managing pediatric respiratory emergencies, clinical insights, and response strategies. Paragraph. And so this is just an acknowledgement that the material presented today is not reflective of the official position of the U.S. government. Next paragraph. And none of our speakers have any disclosures to. So I'll introduce myself. I'm Kim Whalen. I am the nurse director in the PICU at Mass General Hospital. And I have the honor of introducing Allison Cowell, who I was lucky enough to work with many, many years ago. But Allison, after graduating from University of Vermont College of Medicine, continued her medical training, pursuing residency and general pediatrics at the University of Massachusetts, and ultimately the Pediatric Critical Care Medicine Fellowship at Mass General. She remained as an attending in Boston for a year and then moved to Connecticut Children's Medical Center in Hartford, Connecticut in 2008. And there she's been there ever since. Dr. Cowell is the medical director of the PICU, medical director of respiratory care, and the medical director of the ECMO and continuous renal replacement program. In these roles, she has focused on bringing new technologies, therapeutics, and collaborations to the bedside to improve and elevate the quality of patient care, striving to exceed national benchmarks. She collaborates with the pediatric acute lung injury and sepsis investigators doing international work, focusing on various aspects of the care of critically ill patients, and is the key site director for this multi-institutional research collaborative. Her academic focus is on acute respiratory failure, as well as pediatric ECMO management. Allison, I'll let you take it away from here.
Perfect. Thank you, Kim. So yes, my name is Allison Cowell. I'm from Connecticut Children's Medical Center, and I've been a PICU attending for what seems like forever now. I'm here to discuss with you managing pediatric respiratory emergencies. We have quite a diverse group of people who are here, so please feel free to ask any questions. And if anything I say doesn't make sense, please let me know, and I will try to explain. So our objectives for today are to examine the clinical presentation of the acute management of pediatric respiratory emergencies, focusing primarily on asthma and respiratory infections, which are the most common pediatric respiratory emergencies, and to discuss the response strategies and clinical tools that we could use to effectively care for pediatric respiratory events. So the first thing that all pediatricians will say to you is that children are not little adults. So what makes a child's breathing different from an adult's? Anatomically, children are different. They're just not shortened grown-ups. Their head is large compared to the rest of the size of their body. The back of the head, or the occiput, is larger in comparison to the front of the head. Their tongue is in general larger in comparison to the size of their mouth or their oropharynx. At different ages, they have decreased neck muscular tone, especially in infancy. As you could see when you pick up a newborn, their head flops around. The narrowest part of the trachea in children is below the larynx, whereas in adults, it's at the level of the vocal cords. And the chest wall of a child is much more compliant. It moves much easier and is less rigid than that of an adult. So when you put all of those structural issues together, it makes just the physics of the airflow change enough that it can make breathing more challenging, especially if a child is lying on their back and that tongue can fall back and the big back of their head positions their airway in a slightly different position than an adult's. So how do they present with their problems? Well, it really depends on where the issue is that is causing them distress. There's the difference between the upper airway disease and lower airway disease. So in upper airway disease, it's proximal or above the thoracic inlet. And the noise that you hear during that time is what we call stridor. Those are issues primarily of the nose, the pharynx, the mouth, and above the larynx within the trachea. The lower airway we call is distal or below the thoracic inlet. And that the noise that you hear is wheezing, and it happens on exhalation. And those are issues of the trachea, the bronchi, and the peripheral airways. So we'll go through various issues one by one, starting with the upper airway. The most common upper airway issue that children have is caused by croup. Croup is called viral laryngotracheobronchitis. It's much easier to say croup. It is most commonly caused by the parainfluenza 1 virus. It is something that we see often in children 6 months to 4 years with a peak of 1 to 2 years of age. We see it most often in the fall and some in the spring. And there's an annual incidence of about 18 per 1,000 children. So it's pretty common. In croup, edema or swelling develops, narrowing the lumen of the airway, the central area of the airway. And we call that the steeple sign. And if I can get my pointer to work, you can see here on this X-ray, the airway starts nice and broad, the black area, and then it goes down into a narrow little squiggle, and then opens back up into a bigger airway itself. If you were to cut it off here and look just below my pointer, it looks like the steeple on a church, and that's how it got its name. When you have that, very rarely can you develop true complete airway obstruction. There is an entity that is much less common. It's called bacterial tracheitis, and that develops with the same kind of edema of the airway, but it's caused by a bacteria as opposed to a virus. And it ends up giving an exudate or kind of a pus-like material on the inside of the trachea itself, and that can cause an airway obstruction. The difference between bacterial tracheitis and croup is largely that bacterial tracheitis comes with higher fevers than croup does. So what does croup look like? On physical exam, you'll see a child who is tachycardic or tachypnic. Their heart rate is going fast and they are breathing fast. They can look pale, sometimes cyanotic or blue around the lips, and in general mottled. They don't have great color throughout their body. They often don't have as much energy or activity as normal, or they have decreased what we call level of consciousness. They frequently have a low-grade fever, often with a runny nose, and their breath sounds themselves, if you listen to their lungs, are very clear, but sometimes diminished because the air entry is decreased. The hallmark of croup is what we call stridor, and it comes with a barking cough or a sealed cough and a hoarse cry or voice. If I can play this video, you'll get to hear a few examples of what croup sounds like. All right. So those are 3 examples that you can see of different ages and of different severity of illness. All right, well, we'll keep going because it's unfortunate. There's 2 other sounds in there too. But all right, so how do we treat croup? We try to keep the patient calm at all times. Leave them in their parents' arms. I know it's in our general tradition to take a kid and put them on the exam table so that you can have a little bit more control. But in children with upper airway obstruction, it's important to let them stay calm and leave them in their parents' arms. The hallmarks of treatment of croup are steroids. Often we give them as dexamethasone or Decadron, but really any steroid can work, whatever you have. If you have an IV, give it IV. If you don't, give it by mouth if the child can swallow. If you don't have that, but you have nebulized steroids are nebulized work just as well. The other best therapy that we have is what's called racemic epinephrine nebs. So epinephrine has two ways that the molecule is put together, and if you put both of them together and put it in a nebulizer, it allows for a decrease in edema of the airway itself, and allows the air to pass much easier because the trachea itself is decreased, is enlarged, and the edema or swelling on the inside has gone down. In significant cases of protracted difficulty breathing, we use something called Heliox, which is a mixture of helium and oxygen. It allows the air to flow in a more laminar pattern. So that means it's flying in a more straight way as opposed to turbulence. And when air passes in a more straight way, it is easier to distribute to the airways, and the children can get their air better. Heliox comes in two formulations, either 80% helium and 20% oxygen, or 60% helium and 40% oxygen. The caveat with Heliox is that it doesn't work if the child has a high oxygen requirement, because you can only deliver 40% oxygen at the most. We also make sure to give kids analgesia. Like I said, kids with croup often don't have very high fevers, but they don't feel very well. And even just getting their low-grade fever down to normal and giving them some Tylenol can make all the difference in the world. The air that they breathe should be humidified. Old wives' tales always said to take the child into a bathroom with the shower running and a lot of humidification. In the end, in randomized controlled trial, that was found to make the parents feel better more than it made the child feel better, but it did make everybody calmer. And so in that sense, it made croup get better. But we do know that dry air and breathing, especially filtered air, can be harder for the lungs in general on any given day. And so in this case, when you're having difficulty passing air through the airways, it is nice to have humidified air. And then depending on the history that you get of your patient, if the child has not been eating or drinking well, remember this is caused by a virus that can make kids feel pretty cruddy, and they might not be eating or drinking because they just don't feel good. And so it's always good to give them IV fluids to make up for the fact that they haven't taken in enough fluids. The next upper airway disease we're going to talk about is epiglottitis. It is more dangerous than croup. It is generally caused by Haemophilus influenza B, and it is a life-threatening, rapidly progressing infection. Luckily, it is very rare now because we have the vaccination for HIB, or HIB, Haemophilus influenza B, that is given to children starting at 2 months of age. I just bring this up now because with more vaccine hesitancy in the United States, it may be that there are more children who are not getting their HIB vaccine, and so we might see a recurrence of it. The hallmark presentation of a child with epiglottitis is one who sits in a tripod position, so their head is pushed forward, their arms are on their lap, they are pulling their chin up, they open their mouth, they rest their hands on their lap, and they kind of open their chest trying to breathe. We see what we call the 4 Ds: drooling, dysphagia, which means difficulty swallowing, dyspnea, difficulty breathing, and dysphonia. Their voice sounds different. And if get an X-ray or a lateral film of the neck, you see the thumbprint sign. And if you look here on the difference, this is a normal child in panel A, and the little lighter gray area is the epiglottis. It's very thin and narrow. If you look on image B, you can see this light gray area has now become a big, what looks like a curved area. So you could picture me putting my thumb right there on the X-ray, and that would make the thumbprint sign. Also, importantly, look at the way that this child is holding their head. You can see here in image A, the kid's head is upright, the neck is straight, and the head is back. In image B, the child's neck is curved, the jaw is open, the chin is jutted out forward, and their head is literally pushed forward. Children do that because that is the position that they can get the most air in. All right, moving on. So when we move on to the lower airway, we have clinical features of those diseases are defined by tachypnea. Tachypnea is rapid breathing. In children, you have to know the age of the child to know what to expect in their vital signs. So kids who are up to 2 months of age, normal respiratory rate can be up to 60 breaths per minute. In the rest of infancy, it's up to about 50 breaths per minute. In toddlerhood or preschool age, up to 40 breaths per minute. And above kindergarten or school age, we usually go to about 20 breaths per minute. We talk about kids with lower airway disease having dyspnea, or they can't speak in multi-word sentences. And sometimes we joke that children can't cry in multi-word sentences, but you get the sense that if they are saying, "Hi, how are you that they're having difficulty and they have to take a deep breath in between every word. They aren't getting enough air in. We call them retractions, or what some people call recessions. So those are pulling in of the neck muscles and the rib cage muscles. So above the sternum, in between the ribs and below the ribs. We see children grunting. They can develop nasal flaring, head bobbing, tracheal tugging, which is pulling in right here at the thoracic inlet, belly breathing, where in these kids with these compliant chest walls, or a child like the one in the picture that we have to the right has this kind of little Buddha belly that is normal for infants. You can see that move in and out. Some children can become, frankly, apneic or stop breathing altogether. And the hallmark of this is that their pulse oximetry, or their ability to maintain their oxygen saturations, is less than 90% in room air. I know that you're not going to hear this, but I think just by visualizing the various signs on physical exam, even without using your ears, you'll be able to see some of the differences. You see that kid's head's going up and down. That's true head bobbing, very common. Here, that's the thoracic inlet. That's tracheal tugging, pulling in there. Here you could see this child is pulling in using their accessory muscles to pull underneath their rib cage. And this child's doing that as well, except for also using the muscles of the rib cage itself. This you can't hear, but this child is wheezing. He's going, and this is stridor. This is a child who's having difficulty having air enter more from an upper airway obstruction, and that sounds like as opposed to wheezing. I know I'm not a very good actor, but that's the best that I can do. These kids will sound better when you listen to the recording. Okay. So the most common lower airway diseases that we have is called bronchiolitis. It is the most common presentation of any lower respiratory infection in kids under the age of 2, and the most common cause of hospitalization in kids who are 1 year or less. It accounts for about 18% of all hospitalizations in the United States. This has been found to cost about $1.73 billion nationally for bronchiolitis admissions, and it's most commonly caused by viruses. The most common virus of those is RSV, respiratory syncytial virus, but also rhinoenterovirus, or which we call the common cold, adenovirus, human metapneumovirus, parainfluenza 3, as opposed to the parainfluenza 1 that causes croup, and COVID. Historically, we had a seasonality to the presentation where it would start sometimes in November, peak more in December to March, and sometimes last as far as April. Since COVID, however, most pediatricians will tell you that the seasonality of our illnesses has been turned on its head. And so this year in our hospital, we saw RSV in July. So what is bronchiolitis? Bronchiolitis is edema or swelling and inflammation, which end up causes necrosis of dying of the respiratory endothelium, the most inner layer of the airways. And those dead cells make a lot of mucus. It is 100% a clinical diagnosis. There is no x-ray that can specifically say to you, like the steeple sign or the thumbprint sign, that that's what's going on. It is a clinical diagnosis using your ears. Children present with cough, increased respiratory rate or breathing faster, retractions, as we saw in that video, wheezing, some rhonchi, which is kind of crackles and harsh sounds on your oscillatory exam of their lungs, and they can have air trapping areas that don't exhale as well as the others. Bronchiolitis, because it is a virus, is most often spread by airborne droplets. So if a child sneezes, coughs, even laughs, they can spread the virus through their mouth, or they can spread it in contact with objects that have been contaminated. Normally we think that that's not such a big deal, but if you think about the developmental age of different kids, they put everything in their mouth, and they put their toy in their mouth, and then they give it to you and wipe it on your face, then they can spread you the virus as well. This is a problem in daycare settings, especially. So what do we see depending on the age? In adults and older kids, it really just looks like any other upper respiratory infection or a cold. Elderly folks also can get bronchiolitis and also can get RSV disease. Them, it looks more like a bad cold that can sometimes progress onto pneumonia. In infants, though, which is the most common, we have this runny nose, fevers. They don't want to eat or drink because it's hard for them to suck and swallow at the same time as it is that they're breathing so fast. They can end up making noise while they breathe, so wheezing. They cough a lot and they have nasal congestion. Sometimes kids can develop cyanosis, and you have to be careful in the smallest of infants, the less than 1 month olds. They can become cold or hypothermic, and about 28% of children under 1 month of age can develop apnea or frankly stop breathing. Because this is also caused by a virus, as I've said, they can also develop an otitis media that is not a bacterial otitis. It is just an inflammation that's an ear infection, courtesy of the same virus that got them sick with the bronchiolitis. So the risk factors for getting bronchiolitis are age less than 2 years, especially in the 3 to 6 month age age range. Children who are breastfed do better than children who are being formula fed. And that is because breast milk in itself has some immunoglobulins and a passive immunity from the mom to be able to help the child fight the disease. Premature infants have a worse issue with bronchiolitis if they're exposed to cigarette smoke or crowded living conditions, which is not just physically living, but also including daycare. Of note, kids who have congenital heart disease, airway anomalies, or chromosomal anomalies are more at risk of every illness in pediatrics, but especially these respiratory illnesses and bronchiolitis. So how do we treat it? It really is just supportive care. You have to let the virus run its course. We don't have a good medication to be able to, like a antibiotic will kill a bacteria. There's nothing really that we have that can cure viruses in this way. Usually bronchiolitis lasts about 7 to 10 days with a peak of symptoms in day 4 to 5. When we have children who come into the emergency department or inpatient setting, we often ask the family, how many days has the child been ill? If the child is presenting to the ICU and they've only been ill for 2 days, we kind of hold down and buckle up because we think that it's probably going to get worse for the next 2 to 3 days. But if it's already day 4 or 5, we can usually be pretty reassuring to the family that it's going to take, that it's going to start getting better. It's going to take a few days, but the child will be getting better. So as I said, we use supportive care. We give IV fluids, oxygen as necessary. We treat their fevers, and we help them with secretion. Secretion management can be as easily as sucking out their nose with a nasal aspirator to allow them to be able to breathe better when they eat. So there's a lot of things that we have tried because these kids look so sick or uncomfortable, and we want to make them better. But what have we found that is not effective? So bronchodilators, we'll talk about more when we get to the discussion about asthma. These are things like albuterol, not found to be effective. Steroids, not effective, even though this is an inflammation of the airways. Ribavirin, which was a great medication that we thought would actually attenuate the virus and make it be less severe for a shorter period of time, actually was found not to be effective and is a big teratogen. So it was a danger to be used in the hospital with other people who are around who were pregnant. We try to nebulize hypertonic saline or even regular normal saline to see if we can loosen up some of these secretions. The secretions and the things coming out the children's nose are usually pretty tenacious, thick, and sticky. And so if the child plugs their mouth with a bottle and has a stuffed up nose, it's really difficult for them to breathe. So we all have this desire to thin out the secretions that are coming out of their nose. But we found that nebulized hypertonic saline or normal saline really doesn't help anything. It just makes the children angry because you're putting humidified stuff in their face. We can get chest x-rays when these kids present to the emergency department or into the inpatient setting, but it doesn't change the amount of children who actually need to be hospitalized, and it doesn't change their length of stay. And giving antibiotics, especially if we see a child has an ear infection, we have a tendency in this country to want to treat all ear infections with antibiotics. But we found that with a kid with bronchiolitis, routine antibiotics just increases complications. Most commonly, these are pretty mild complications, like in the setting of kind of some increased diarrhea or gastric upset. But it doesn't decrease the duration of symptoms. It doesn't decrease the need for hospitalization. And once hospitalized, it does not decrease a child's length of stay. The most common cause of bronchiolitis is RSV. And so I wanted to call it out specifically. 90% of kids have had an RSV infection by the time that they are 2 years old. That doesn't mean all of them have sought medical care or even gone to their pediatrician for any reason, but 90% of kids have had an RSV infection. So one of those boogie nose viruses that you see kids come home with in their first toddler age group is probably RSV. It's responsible for 60 to 80,000 admissions in the United States of children to the hospital per year and can cause upwards of about 300 deaths per year. So because of the burden of this and the population-based mortality, there's been a desire to try to stop children from getting so sick. 1998, there was a monoclonal antibody that was developed that we called Synagis. It had a lot of promise, but in fact, it was found to just not be as effective as we had hoped. The deal with Synagis was you needed to have monthly injections. And children would have to go to their pediatrician once a month to get a shot in their leg. It is exceedingly expensive, and it really only had most efficacy in high at-risk populations, which were those who were extremely premature infants born below 32 weeks gestation, children with known congenital heart disease, kids who are on oxygen at baseline, kids who had what we call bronchopulmonary dysplasia or respiratory distress syndrome secondary to being premature. In May 2023, however, there was a vaccine that was approved for pregnant women. It's been given to women who are 32 to 36 weeks gestation before delivery. And this vaccine allowed for a decrease in ED visits and hospitalizations of the children born to those women by 50 to 60%. In September of the same year, 2023, there was a monoclonal antibody that was approved for use in infants. So this is not a vaccine, but monoclonal antibodies help the body fight infections. And this, as opposed to the Synagis monoclonal antibody, is a one-time shot. By giving this one-time shot over into infants, we were able to see in the 2024 to 2025 viral season, which was just this past year, we had a decreased prevalence of what was diagnosed as severe disease by 75% in the first 150 days of a child's life. And there was a decreased number of ED visits by 70%, and a decreased hospitalization of 81%, and a decreased need for ICU admission by 90%. And I can say just for my ICU alone, our number of admissions for bronchiolitis last year was dramatically different than what we had seen in the past. We really had very few admissions for otherwise healthy children. We did have admissions for the children who are compromised at baseline, but not for otherwise healthy children. So this may be revolutionary in what we see going forward in pediatrics. The next lower respiratory or lower airway infection that we see is called pneumonia. Everybody's heard of pneumonia, I'm sure. Pneumonia is an acute infection of the actual lung parenchyma, the actual lung tissue itself, not the airways alone, but the actual lung tissue where the air is exchanged. It accounts for about 14% of all deaths in children in the preschool and infancy age, and in 2019 killed 740,000 kids. Pneumonia can be prevented by the use of immunizations. There is an immunization that's called Prevnar that's out there, and PCV7, and now PCV23 that treat the most common strains of streptococcus that causes most pneumonias in children. By keeping kids well fed and with adequate nutrition, those who are undernourished or malnourished for whatever reason have a much more difficult time fighting pneumonia. And minimizing negative environmental factors like indoor air pollution, especially parental smoking, and living in crowded homes. So here we have an X-ray of pneumonia. Pneumonia can be caused by a virus or a bacteria. The interstitial pneumonia, which is not seen necessarily in this picture, is a kind of more fluffy pattern, and it is more often caused by viruses. Most commonly, that RSV, as you get older, can cause RSV pneumonia. Influenza causes a pneumonia, and human metapneumovirus causes pneumonia, as well as many others. COVID also causes pneumonia. And then there's lobar pneumonia, which is often bacterial, and that's what we're seeing here in this film. We see here in this area over here, all of this extra white is interstitial edema and airways that are not able to exchange gas. This area here is the heart, and you're supposed to see a nice border as you do up here. See how there's a difference between the white and the gray? You're supposed to see that all along. And the fact that it is blurred now is because that there is a pneumonia there. So the bacteria that most often cause this in the infancy, the neonatal age, it's usually Klebsiella, E. coli, or Staphylococcus. And then in most infants and toddlers, it's that strep pneumonia or H flu, not the Haemophilus influenza B that we saw in epiglottitis, but what we call non-typable, so a different type of Haemophilus influenza, and then Staphylococcus. In kids over 3 years old, we don't have as much of the H flu, but it's really just the strep and the staph. And then there are these atypical pneumonias called caused by something called mycoplasma pneumonia. And mycoplasma is, we used to say, occurred most often in school age and older, and it was the cause of what adults call walking pneumonia. But now that many, many more children go to daycare, which is in effect the same kind of environment as school, we see mycoplasma down to 1 and 2 years of age as well. In kids who are immunocompromised, either because of a known immunodeficiency that is congenital or because of chemotherapy or other immunosuppressants, they can get something called pneumocystis carinii or PCP pneumonia, which is much more difficult to treat and is important to figure out because we treat it differently than we treat all the rest of the pneumonias. So how do we treat it? We give antibiotics. We play the odds based on the age of the child as to which antibiotic is going to be the most helpful. The majority of children do very well with the penicillin-based antibiotics. So amoxicillin is the one that is most commonly used in pediatrics because it comes in a nice bubblegum flavored liquid that most kids don't have a problem taking. Viral pneumonias just get careful observation and supportive care, just like viral bronchiolitis. When discussing pneumonia, we all get worried about it, but we try to think about which ones actually need to be hospitalized. So the IDSA, the Infectious Disease Society of America, has put out recommendations for when to hospitalize children. And those are those who have sustained pulse ox or SAT less than 90% in room air, those who have a suggestion of bacterial pneumonia who are 3 to 6 months of age. If there's a concern that the child is not going to be able to get their antibiotics or follow up because of some stressors at home, especially in the unhoused population, amoxicillin needs to be refrigerated. And if the family does not have access to consistent refrigeration, that becomes a problem. And then we need to admit children who we think might have community-acquired pneumonia from something that has a higher virulence or not a normal pathogen. Specifically, MRSA is the most common of those. MRSA is in about 30% of our community, so if a kid is not getting better with amoxicillin, we get concerned that it could be from that. All right. Moving on now out of the infectious processes into asthma itself. Asthma is a triad of issues of the lower respiratory tract. So there's bronchospasm, bronchial edema, and increased mucus production. So physiologically, what happens on the left-hand side here, you see a diagram of what a normal airway looks like. That the muscle itself contracts and makes the lumen of the airway smaller. The airway liner, which is this light pink area, also gets thicker, gets swollen. And then because of all of that, you end up with mucus plugs of the extra dead skin cells or dead airway cells kind of block the airway. And all of that together takes a nice big open airway like you see here on the left, and you try to pass the same amount of air through this airway on the right, and you have difficulty, the child has difficulty breathing, or the adult. So what do we see with that? Children have dyspnea or difficulty breathing. They have nasal flaring, tracheal tugging, use their accessory muscles, have suprasternal, intercostal, or subcostal epigastric retractions. They can have a significant cough. They can have an expiratory wheeze. They can have tachypnea, and they can have cyanosis, which is turning blue around the lips and the fingers, usually most commonly. I will tell you a personal anecdote. I have significant asthma, and one time I didn't think I I was doing so poorly and was going about my day, and I was sitting quietly in my home office, and my husband walked by and said, "Where is the train? It sounds like there's a train whistle." And that was me breathing. And that was a sign that I probably needed to see a doctor. So that the expiratory wheezing, that's a child trying to push the air through those airways. So what do we ask when we see a kid who has asthma? We ask them to describe their breathing. Kids who are verbal can tell you what it feels like. We ask the family or the child, how long have they been wheezing? How long have they been having difficulty? Have they been eating and drinking normally? And have they had a normal amount of wet diapers? Have they had other recent respiratory tract infections? Have they taken any medicines for this? When was the most recent dose? Because you want to know based on your exam whether or not, if they sound great, is it because they had albuterol right before they saw you? Or was it because they had albuterol yesterday and they actually might be getting a little bit better? And how often have they been getting, or how much of those medicines have they gotten? Do they have any allergies? And these aren't just allergies to medications, but environmental allergies. You can get asthma from an allergic response. And we often see this in ragweed season with kids who go outside and play because it's still beautiful weather outside. And then all the flowers bloom and they're allergic to whatever that pollen is. And then they start to have asthma. And then importantly, when you're trying to triage these patients, you want to know, is this their first episode of asthma? Have they had previous hospitalizations, previous ICU admissions, or previous need for intubation? So what are the answers that make you more concerned? When the kid says, I can't get air in, or my chest is heavy, or every time I take a deep breath, I cough, that gives you a sense that they're struggling more than you would think. If a child is like, I'm able to run around and play and go to gym class without a problem, then they're in a better spot. Kids who have who have needed to be seen in an emergency department more than 3 times in the past year, or been admitted more than 2 times in the past year, or have been to the ICU, or certainly if they've been intubated in the past, should heighten your awareness that they need to be treated more aggressively upfront. Kids who have used more than one MDI or bronchodilator canister in the past month have can give you the sign that they are self-treating their issues, their discomfort on a more regular basis than once or twice a day, which is what those canisters are supposed to be used at their max. If kids are having an asthma exacerbation, if they are needing for the short term, use of albuterol more than every 4 hours to be able to keep their symptoms at bay, that is concerning. If they've been on steroids often in the past year, that gives you a sense that their asthma or their reactive airway disease is more tenuous than somebody else's. And if they're getting worse despite doing everything that they can at home, that should get you concerned as well. So this is a picture of a child who's having difficulty and her mom holding her MDI or her meter dose inhaler, her albuterol. Because if you see this kid, she's sitting up, laying down, it's harder to breathe. So if a child has to sit up, that gives you a sense that they're having more difficulty. This child isn't actually completely tripoding, but you can see her shoulders are rolled forward. She's holding her chest and she's trying to stent open her chest itself. She's coughing, but sometimes children look drowsy or what we call stuporous. They can also look scared. When a child, infants and toddlers have stranger danger and they don't like to be seen in a medical facility at all. But sometimes even in bigger kids, they can give you these wide eyes of something very bad is happening, gives you a sense that they are very scared, not just, I don't like you, you're a stranger. Kids can have signs and symptoms of dehydration, so their lips are cracked or their mucous membranes are not as moist as they should be. You can watch their chest move itself. So if, like this child, she's shoulder shrugging, or if they're pulling in and they have those retractions, that shows that they're using more effort to be able to get the air in and out. If you can hear the wheezing, if they don't have the ability to speak, those are all signs that you can see from the outside. And then once you put your stethoscope on their chest, you can listen to the quality of their breath sounds if you hear the wheezing itself and how much air entry you hear. The treatment of asthma, the hallmarks are bronchodilators, usually beta-2 agonists, and the most common of those is albuterol. You can see this little girl on the right-hand side is using an MDI with a spacer, a meter dose inhaler with a spacer and a face mask. This is the easiest way to give albuterol at home to a toddler. They don't know how to put their mouths around the actual mouthpiece like a bigger kid can, but they can open their mouth and nose and breathe in through that by using this face mask. Also, allowing for the spacer allows the particles that come out of the MDI, the medicine itself, to kind of bounce around within that spacer and make the size of the molecule smaller so that when the child breathes them in, it goes down their little airways and gets further and deeper into the lungs themselves. The big management thing is the use of steroids. You can give those by an inhaled method, there is an MDI for steroids. There's also nebulized steroids. You can give them orally, or you can give them IV. Oftentimes we say with asthma, what we need to do is buy time to allow the steroids to do the heavy lifting. The steroids are going to be the things that decrease the inflammation of the airway and of the lung parenchyma to allow gas exchange to go better, but you just have to buy your time to be able to get there. Now in pediatrics, and I believe in adults as well, there's something called SMART therapy, which is using not just the traditional albuterol alone, and then sometimes steroids alone, but there's combination medications that have both these short-acting beta agonists, which is what albuterol is, long-acting beta agonists, which are sometimes called LABAs, and steroids all in one together. A common one that is used is called Trilogy, and it has all three things in the same spot. We also need to remember with kids who have asthma, they're breathing hard and fast, and so they have increased insensible losses through their mouth. They're breathing out a lot of their moisture, and so they actually need to drink more than they normally would. And we provide oxygen as needed to help stabilize them and support them until their airways edema goes away. Status asthmaticus is what we worry about most in the inpatient setting, and it's defined as an asthma attack that's unresponsive to intermittent inhaled beta agonists. So the MDI that you give once or twice, or a nebulizer that you give and then they go about their day, those are intermittent. Remember, with these kids especially, if you listen to their chest, no wheezing isn't always a good thing. Sometimes they have something called a silent chest, and you can't hear any air movement. So you can feel good. Oh, look, the kid isn't wheezing. But then if you pay a little bit more attention and you listen a little bit harder, you say, I actually don't hear any air entry. And that means that their airways are really quite swollen and the air is having much more difficulty. So how do we treat status asthmaticus? We give continuous beta agonists or bronchodilators. So you can see this little boy is holding his nebulizer. So the mask goes over his face. It's supposed to fit a little bit tighter and be a little bit smaller. That's a big one for him. And in the area that his hand is around is a reservoir of fluid that is the albuterol. And the blue area underneath is the attachment to an air compressor. In the hospital, we use oxygen, but you can use an air compressor at home. And it nebulizes the fluid that's in the little cup underneath his fingers, and it comes out. And kids that have status asthmaticus, we put that around their face and we just leave them on continuously, and they just constantly are breathing in with every breath their albuterol. We can also give them Atrovent, which is a medication that's often used with COPD, but it actually allows for drying up of secretions, and it's what we call a mast cell inhibitor, and can make some of the allergic response that is causing the asthma get better. We give frequent steroids. So at home, kids can sometimes get either the inhaled steroids once or twice a day, or they take oral steroids once a day. If a patient comes to the ICU with status asthmaticus, they get IV steroids every 6 hours. We give them quite a bit because, once again, we're going to try to get the steroids hard and upfront to be able to do the heavy lifting, to be able to get the airways better, and then everything else will follow. We give magnesium. Magnesium allows for smooth muscles to relax. So if you think back to that image that we had of the muscular area of the airway that's gotten contracted, magnesium allows it to relax. And so it physically makes the airway get larger. Methylxanthines, which the most common of these is aminophylline or theophylline. These are medications that have some controversy, but are coming back into fashion now, and they do allow for more air entry. If a child is in a really, really tough scenario, you can give them subcutaneous shots of epinephrine, kind of like an EpiPen, but that goes into the intramuscular space. And this you would give just under the skin, and that actually can allow the bronchioles to dilate. We give IV beta agonists. So the inhaled beta agonist that we most commonly use is albuterol. We can give IV beta agonists called terbutaline, and it works it's just another way of targeting the same receptors to be able to try to open up the airways as much as you can. Once again, we give them IV fluids because we think that they are very likely to be dehydrated. And then Heliox, we discussed this with the group, but this is the helium oxygen mixture as a reminder. And it allows for the laminar flow of air so that it can potentially get in and out faster and easier. In worst case scenarios, we put kids on positive pressure ventilation or intubate them at the absolute worst cases. So what do you do? In general, remember that respiratory urgencies can quickly progress to respiratory emergencies. So I highly recommend finding a system that works for you and approach each patient in the same way. There are tons of scoring systems out there for individual disease processes, for asthma, for bronchiolitis, for all sorts of different things. You can use them, or you can use a system that works across the board regardless of what a child presents for. Examine the patient, then go back and re-examine the patient and re-examine the patient again. Especially in pediatrics, exams change quickly and are very dynamic. And each exam might give you a different sense of what's going on. Once you are able to figure out how to intervene and provide treatment, please go back and reassess the efficacy of your treatment by re-examining. And then most importantly, figure out what's the life-threatening thing, address that before moving on to anything else. So I know we're short on time, so I'm going to quickly go through these. Step one would be looking at the airway. We've discussed this with the group. Look to see whether or not you can see difficulty breathing, cyanosis, depressed consciousness, no breath sounds, or one thing we did not discuss was if the eyes are rolling back in the head, the kid is not able to get enough air. That's a problem. Airway obstructions are a medical emergency that should be addressed first and foremost. Sometimes you can do it just as easily as picking up the child's head, sitting them in a sitting up position or chin lift or suctioning out their airways, but sometimes you need to put in a breathing tube. Always give oxygen. From a breathing perspective, just as we have discussed multiple times, look for signs for respiratory distress, and I don't think we need to go through all of these as we have short time. Circulation. So the most common cause of cardiac arrest in pediatrics is hypoxemia or poor oxygenation and respiratory failure. So think about in kids who have shock, it's likely due to low oxygen and hypovolemia or dehydration. The way that you can see those is poor pulses, an increased heart rate, low blood pressure, low urine output, and that they're not taking good PO. When in doubt, you can always give kids IV fluids. Step 4, in the pre-hospital world, we talk about D for disability or coma and convulsions is the most common that we see in this, or seizure-like activity. We say in the ICU, altered mental status is hypoxia, hypercapnia, or hypotension until proven otherwise. So low oxygen saturation, increased carbon dioxide, or low blood pressure until proven otherwise. Or more importantly and more commonly is dehydration. And last, exposure. Remember to check the kids' temperatures. The temperature can actually let you know what's going on with the kid much faster than it would with an adult. Kids can become hot or cold, either febrile or hypothermic, much faster than an adult. Look all over the kid's body. Don't be afraid to unsnap their onesie and look at how they're breathing. Don't forget to check their back or their diaper area, and look for rashes. Rashes can be a hallmark of various viruses. And then most importantly, know where your resources are. So in many facilities, you'll have the Breslau tape. It was updated in 2017 or 2018 to have more medications on it, not just information about an active CPR resuscitation. In that vein, you can use your PALS card or Pediatric Advanced Life Support. Lexicomp and Neofax are great resources for drug dosing. OpenEvidence.com is a relatively new AI site that you can type in questions and will give you answers based on evidence-based medicine. UpToDate is an older one of the exact same thing, but has very nice summaries of disease processes. Don't be afraid to phone a friend and call a children's hospital or children's provider. And actually, critical care transport teams have advanced pediatric training, especially in the critically ill children, and so they can often be a resource as well. So when in doubt, keep yourself calm, keep the patient calm, keep the parents calm too. Remember your normal vital signs for age, and then give oxygen in whatever way you can. Try to pick a device that actually fits the size of the child. Not every kid can handle an adult-sized face mask. Please, when you're not sure about what's going on with a child and they're not breathing well, don't feed them. They have difficulty eating and drinking at the same time that they're breathing so fast. And once you get that stuff taken care of, then you can figure the rest out. Always remember, children are not small adults, or like we say in pediatrics, adults are not big kids.